السلام عليكم، صباح الخير. اليوم نتكلم عن OCT glaucoma. Short topic. إن شاء الله it will be easy. First, our rationale for retinal nerve fiber layer thickness assessment. The IOP and cup-disc ratio may not be sensitive enough as indication of glaucoma. For example, ocular hypertension, physiological cupping. Small changes in the appearance of the optic nerve head may be difficult to detect by ophthalmoscope. The only definitive sign of glaucoma is progressive loss of REM over time. The visual field loss occurs relatively late in the disease with poor sensitivity in early glaucoma. So nerve fiber layer analysis may be the most sensitive in early disease. Methods for assessment of the nerve fiber layer, we have red-free ophthalmoscope and older type of machine like scanning laser polarimetry, confocal scanning laser ophthalmoscopy, and the relatively new optical coherence tomography. Why use OCT in glaucoma? It's an objective measurement, allows automated analysis and reproducible results. So optical coherence tomography uses the reflected light. Light beam is simultaneously sent to the eye and reflective mirror. The light is penetrating through the ocular tissue layers and reflected back. The returning light is compared with the reference and allows the computer to reconstruct the underlying tissue. So as we can see here, the OCT machine produces a light, and then the light goes through the ocular tissue to the retina and back to the machine and reflects to the photodetector. Another beam of light goes to a reference mirror and goes back to the photodetector. The machine will compare the two reflected lights and produce an image. So this tells us that anything obstruct the light will affect the OCT. If we have a media opacity, if we have poor dilation, even if we have dryness, it will affect the image of the OCT, because the light will rely on the refractive power also of the eye. We have two types of OCT, time domain OCT and spectral domain OCT. Time domain is a measurement of time of light delay. It uses a moving reference mirror, and the depth of resolution is 10 microns. This type of machine is slower than the eye movement. As we can see here, the reference mirror can be moved, and the machine will collect the data and produce an A scan, and from this A scan will produce a B scan image. Spectral domain is a stationary reference mirror, and it is a higher resolution than the time domain, with the depth of resolution ranging from 3 to 6 microns. And it is faster than the eye movement and produce better quality image, faster image also. So these are the different types of OCT machines. Most commonly used is the Zeiss and the Topcon. We have the Topcon 3D here in our clinic. There are 3 parameters relevant in glaucoma. We rely on. The first one is the retinal nerve fiber layer. Second one is the optic nerve head. Third one is ganglion cell complex. We usually order the first two. Sometimes we need to order the third one. So the retinal nerve fiber layer, one of the maps we can see is the TSNIT map, which is short for temporal, superior, nasal, inferior, and temporal. Displays the nerve fiber layer thickness values by quadrants and clock hours. Nerve fiber layer thickness peaks gives a sense of the anatomical distribution of the nerve fibers, actually represented by the superior and inferior bundles that are spread out from the optic nerve. As you can see here, the superior and inferior quadrants are the thickest and represent the peaks. And This is just a cross section of the nerve fiber layer around the disc. So OCT can detect and measure and quantify the nerve fiber layer thickness by circling the area between the inner limiting membrane and the retinal nerve fiber layer border. It uses a circular scan around the optic nerve head with a radius of 1.7. Starts temporal and goes anti-clockwise until it reaches the same area. And this is the image what it produces, and it can calculate the thickness of the nerve fiber layer and plot it in this graph and compare it with the normal values. The normal values are matched with age, so it's very important to put the date of birth in the machine so the machine can compare the results. As you can see, the green is the normal, the yellow is the borderline, and the red is the abnormal. Okay. Another map we can see for the nerve fiber layer thickness is the retinal nerve fiber layer thickness map. As you can see here, it's color coded. In this machine, the red is the thickest and the black is the thinnest. This is the TSNIT map. This is another way to see. Also, this is the nerve fiber layer thickness. This is TSNIT map, thickness map. And these are basically the same, but divided to quadrants and clock hours. So the average nerve fiber layer thickness, superior or inferior, is roughly for normal patient about around 102, early glaucoma 77, moderate 66, severe 53, and for blind patient with advanced glaucoma 45. It can vary depending on the age and the type of machine. The nerve fiber layer thickness will never go below 40, even if the nerve fiber layer is totally atrophic, because the machine will measure the remaining glial tissue. This is what we call a floor effect. So in early and moderate glaucoma, progressive thinning of retinal nerve fiber layer measured by OCT is a very useful tool to judge the progression of the disease. At advanced stages, OCT is less useful due to the floor effect of the retinal nerve fiber layer thickness. In these advanced cases, the retinal nerve fiber layer rarely falls below 50 and almost never below 40. This is due to the presence of residual glial tissue and non-neuronal tissue, including blood vessels. At this level, serial visual fields are most useful to judge the progression. So even if you have end-stage glaucoma, most of the nerve fiber layer is gone, you will not have zero thickness, because still there is other tissues. Whenever you see zero thickness, that means there's something wrong. Most likely it's an artifact. As you can see here, is advanced glaucoma in this stage, the total cupping, thinning all around, but does not reach zero. We see this in this image. Here, the thickness reaches zero in this area, the dark. Also here, you can see it goes all the way down. This is not right. This is an artifact. Second parameter is the optic nerve head assessment. So the optic nerve head analysis, optic nerve scan are composed of 6 linear scans in spook pattern spread by 30 degrees intervals centered in the optic nerve head. So the machine will take 6 scans like this. Each scan will calculate the disc size and the cup size and can generate other measurements. So for the disc size, the machine will determine by measuring the distance between the terminal ends of choroid at the level of the pigmented epithelium. As you can see here in the green line, the machine will measure this, and this will be determined as the disc size. And then the machine will draw another line, 140 microns above the green line, to determine the cupping and the neuroretinal rim. This is the cupping. When the machine draws 140 microns above the green line, the inner area is the cupping, and anything above it Any tissue above it is the neuroretinal rim. After doing that in all 6 lines, the machine will draw dots and will have dots and will connect them to develop the shape of the disc and shape of the cup. The optic nerve head analysis will show like this in the machine. It will give us the rim area, disc area, cup disc ratio, vertical cup disc ratio, cup volume. Okay, so this is an OCT result from Topcon machine like the one we have. And this is usually what we order, the retinal nerve fiber layer and optic nerve head. As we can see here, it has all demographics. It has color fundus photo, thickness map, significance map. Any significant changes will show color coded here. Bed-free map. This is the retinal nerve fiber layer thickness map, TSNIT. And this is the average thickness map, the quadrant, the clock hours. And this part is the optic nerve head assessment with all the data. Disc area, cup disc, cup area, rim area, cup disc ratio, vertical, linear, cup volume, rim volume, horizontal disc diameter, vertical disc diameter. All of this data can be generated through these lines. Okay, it's the same thing, but for bilateral. Also, the machine can add the nerve fiber layer symmetry between both eyes. Okay. Third parameter is the ganglion cell layer complex. Ganglion cell layer is the thickest at the paramacular region. Decreased total macular thickness has been observed in glaucomatous eyes, likely due to thinning of the ganglion cell layer in this region. It's indicate early glaucoma. The area measured is 7 by 7 millimeter. Segmenting the ganglion cell layer alone is very difficult based on the reflectivity. So some machine, they will measure the ganglion cell layer plus the inner plexiform layer. Other machine will add the nerve fiber layer also. The machine cannot detect only the ganglion cell layer, so it will add other layers to it. So this is a normal macula of normal patient, and the glaucoma patient, you can see the difference in the thickness of the ganglion cell layer complex. The result will show up like this, as we can see here, thickness map, and we can see the superior thinning in the left eye. Usually we try to compare the superior and inferior with the inferior quadrants, as glaucoma tends to have difference or asymmetry between the superior and inferior. It's another machine with the ganglion cell layer map with different thickness map and different mode, GCL plus, GCL plus plus. This is basically different layers measured by the machines. And this is very useful in early detection of glaucoma. Okay, so we have our 3 parameters. Now we need to start practicing and reading some OCTs. First, we need to check the name and the eye and the date of birth. And then we should ask what are the obvious changes in the retinal nerve fiber layer profile. Are changes consistent with the disc, and are the changes consistent with the visual field appearance? Okay. And also we need to keep in mind this graph, as you can see in the OCT, whenever we have any thinning, we need to correlate with the disc and with the visual field. So if we have thinning here, and the visual field has an effect there, it's most likely significant. It's accurate. Okay, so we have some cases. Let's see single pH. Can you describe the disc? It's not clear here. What is this area? Okay. How about the cupping here? What do you think about it? It's good. Oh. How about there? How is the cupping here? Yeah, its image is not clear, but if we can look closely, you can see here. This is the edge of the cupping. The left eye is especially, it's not clear in the monitor, but very thin inferior rim in the left eye. Okay. So what do you expect in the OCT?
Okay, so it's completely thinning in the left eye.
Okay.
I would expect to OCT to have inferior retinal fiber line.
Okay. About the visual field?
Shows to be
Yes.
visual field.
The OCT, what do you think about it? Can you comment on it? So first we need to check the demographics. Everything is fine, and then you need to
Check the
fiber layer thickness. Okay. Let's see this one. The superior and inferior are thick, which are normal, and here something is missing. So it's thin here, right? Also, deviation map. You can see here, red area. It's deviated. It's abnormal. This area is abnormal related to the age of the patient. Okay. How about here? Okay. Yes. Also the quadratic clock hours, inferior and inferior temporal. Okay. How about the optic nerve head assessment? This is the rim area. Well, it's the same thing. The color code is the same thing. The red is abnormal. So the rim area is abnormal in the left, while it's normal in the right. Cup disc ratio, see, check the vertical. Here it's 0.5, here's 0.75. So it's definitely a difference. Okay, what is this test? Yes. And what does it show?
Show that there is clinic in the south of the left eye.
Very. It goes with our diagnosis. And this is a visual field, as you mentioned. In the left eye, they have superior visual field loss. Right. The next case wants to take this one. Mohammed.
It's too dark on the spot to something in the picture. Of the left eye showing up to this ratio on 8.75 to 8 plus size. See the better. The vessels. Same thing.
How about the rim? What do you think about the rim? Is it, you see any focal changes, notching, or any glaucomatous any signs other than the cupping? It's also have bigger biliary atrophy here. It does look like tilted a little bit. The vessels are here. Fine. But the rim you can see it's roughly symmetrical here. Could this be glaucoma?
Could be.
Yes.
There's no other finding than the larger to start in.
So you do OCT and this is the result. What do you think about it?
First we'll check the demographic and then to the nerve investment. See the superior indicator blood lines are the superior indicator. Showing good red. Unstable.
Okay. So here,
Here showing here because it's thinning.
okay,
So it's the same.
okay. How about now? Do you think it's glaucoma or not?
With the deviation map, it's thinning to be inferior.
Okay. Would you do something else?
Yeah. Ganglions.
Okay. What else?
Visual.
Yes. So what do you think about the field?
So,
Yes. Okay. So we have cupping. Yeah, almost symmetrical, but we have tilted disc. We have some nerve fiber layer changes, but with the normal field. If I told you this patient doesn't have family history of glaucoma, IOP is normal, central corneal thickness is normal, he's young, do you think still he has glaucoma? Yes, exactly. So this is just to show you that you cannot rely on one test. Sometimes you have nerve fiber layer thinning, but this is related to the shape of the cup. Yes, tilted disc, myopic fundus. This is the normal for this patient. You should follow him as he has large cupping and some changes here, but cannot diagnose him as glaucoma just based on the OCT. So you need to take the age, the race, family, history, IOP, corneal thickness to give us a risk assessment of glaucoma. And then we examine the patient clinically and we have pre-test probability of having glaucoma. And then we do the test, and then we have the post-test probability of glaucoma.
So better often disk sizes that also varies.
Yeah, also, this could be here it's measured scaling 1.9, 0.8. But it does look, maybe it's not the same image. Yeah, but this one, the image does look large. It's another reason. If you have large disc, you can have large cup. طيب.
طيب when you hit this one, big cut of numbers.
thickness ما قصدك أي واحدة هذه ما يعتمد على حسب البيشنت. يعني مثلا هنا محطوط عنده مثلا 90 جاي بوردر لاين، بيشنت ثاني بنفس المشين يطلع 90 يطلع جرين، تختلف لأنه حسب الايج، حسب المشين يختلف، ما في يعني نمبرز كان. there is يعني gradual decrease in the thickness with age normally thinning with age. طيب احنا طبعا قلنا في symmetrical thinning. إذا كان في symmetrical thinning, okay, it's either physiological or symmetrical glaucoma, which is unlikely. Usually glaucoma they are not exactly the same, and as in this case. See, the thickness is the same, the coupling is the same. When you see it, it's most probably physiological, especially if you don't have other normal tests. Okay. Third case wants to take this. Marwa. Yeah. Okay.
Also, was mentioned this more aid, is
Okay.
Also there.
Okay.
In the deviation mark, also there is border.
Yes.
Going to the thickness of the doesn't show anything. Over in the clock hours in the template shows band. Is it defective?
This one.
Yes. The band.
So you can see the color here. Green is normal. This is borderline. Red is abnormal. The white is above normal. This is more thicker than in the normal.
So thickness. This natural.
Yeah, this one I talk about. This is compared the thickness of the neuroretinal rim in both eyes. There is difference. This is the right eye, and the dotted line is the left eye. You can see there is difference in the size. How about the optic nerve head analysis? Yeah, rim area of this ratio is the difference between 7.7 and 0.6, 0.77, 0.6. So this is normal or normal test?
The edge.
Yes. So even if you have no nerve fiber layer thickness is green, does not mean this is normal. It can be something here. We need to keep an eye on the patient also. The nerve fiber, the neuroretinal rim is thin. The cupping is asymmetrical. Thickness of the nerve fiber layer is good, but these are abnormal. So we need to keep an eye on the patient also. Okay. So take this. Yes, sir. Yes. So just first comment on the disc.
So patient has a large disc ratio by function. Maybe in the right eye there is function is
Okay.
for
What field?
I have to see the visual field indices to see this reliable system.
Yeah, just to give you an idea.
And global.
Yeah.
Okay.
About the OCT.
The OCT, there is an optic nerve system
Mm.
based on the critical outlets. That means CP infected. I have to see the number of the disc area. It's CP infected superiorly and inferiorly.
Okay.
And the retinal nerve fiber layer, the quadrant map, that's also affecting both eye superior and inferior. Also the our
Yes.
more affected superiorly.
Okay.
That will be for glaucoma.
And the optic nerve head analysis. It's also all red, and it's all abnormal. So what is this?
So this way I have to patient
Yes. طيب, in this case, do you want to follow him up with OCTs? Or is it
to follow up patient clinically, OCT and visual.
okay? But what do you think? What the thinning here? It's very thin. Do you think 50, 60? Do you think the OCT will be helpful in this case?
I don't think so. The patient has seen it.
Yes. And also, as you can see, the visual fields very advanced glaucoma. You need even 10-2 for follow.
That's why
In these cases, this is 10, this is 30. These cases, you need, when you have severe or advanced glaucoma, as we mentioned before, the OCT is less sensitive. OCT is good in early glaucoma. When you have advanced glaucoma, you will, it's less sensitive and the changes will be very minimal. Patient can progress with very minimal change in the nerve fiber layer. Why? Because he has only a few nerve fiber layer left. The rest is glial tissue and other tissue. مقارنة بالنورمال patient عنده nerve fiber layer كذا glial tissue أو other tissue كذا. إذا صارت أكثر من النيرف فايبر لاير تيشو بتصير sensitivity قليلة فما يبين لنا. These cases best to follow them with visual fields. Okay. We also take this. See?
This example 5, you can see that the average electronical thickness is increased in both ends. The thickness map, you can see that there is black horizontal band both ends.
Okay.
It is corresponding to an area of thinning to the right. On the right eye, I can see there is thinning in all quadrants, and the left also in all quadrants.
Yes.
This parameters,
And the thickness scale.
thickness curve is there is thinning in all the quadrants.
Okay. Okay.
And the rim area, this area, they're all colored in gray. This ratio is 0.88, 0.8. Significant for coming.
What do you think about this test?
Looks something like this band, black band, looks like an artifact.
Okay. So black is 0.
Yeah.
So here you can see touching the baseline. All these are artifacts. You can see here the alignment, the machine. It's not accurate. All of this thinning because of missing data. Okay. How about this one?
Same also.
So what would you do when you see test like this?
I'd like to know what's the cause of this artifact. I might consider repeating it once I see the artifact. I would not consider this test as reliable, rely on the other parameters, such as the visual field and the thickness Ganglion, so on.
So yeah, usually here they repeat if they have poor quality, they repeat. Still poor, they will keep it. Depends on the clinical for the patient. If it's like this patient's mild cupping, isn't like glaucomatous, you can repeat if we get an image like this. It's good. If we could not, we can just follow the patient and repeat again in different time. As we mentioned, anything can affect the image. We have even dryness, patient moving his eyes, blinking, whatever. Yeah. Small pupil. So, last case, who wants to take this? So let me ask you, what do you think? What is going on with the left side here? Yes. Who answered? You?
Sorry for answering.
Yeah.
Oh,
Yeah, so malated nerve fiber layer. Any other conditions can affect the OCT. We have malated nerve fiber layer. Will have very thick reading like this. Okay. Same thing if we do the GCC or finger cell complex. If you have any macular disorders, it can affect also your reading. you have papilledema, if you have whatever fluorescence, it can affect the thickness of your OCT. There's no like one, you cannot rely on one test. In OCT, you need to repeat. You need to repeat and follow and see, because each patient has his own normal ratings. Questions?
Should be repeated each visit in the bills.
Depends on the severity of the glaucoma. OCT is easy, simple procedure, fast. You can do it every 6 months or even less if you're concerned. For field, you can do it every 1 year. It also depends on the patient condition.
Used to, the OCT with the carcass, or used to be before
Yeah, we start using it early. We can do it in the beginning when you first have the patient. We should do all the tests and assess the patient. If the patient is advanced, both eyes, the importance of OCT is very minimal. Should rely more on visual fields. Okay. But if, for example, he's advanced in one eye, mild, moderate in the other eye, should do OCTs to follow the other eye. Also, when you want to compare OCTs, you don't take one reading. And if you, for example, you saw one patient today and you do OCT, there is thinning compared to the last one. But everything is normal. You don't suspect he's progressing. You don't jump and treat the patient or over treat the patient. It can be something wrong with the test. You can repeat it later on. You can give him near appointment and repeat it again. Do other tests. So we should take the patient as a whole. We should see him clinically, do all the tests. We don't rely on one thing.